Alright, so we are back on AC4. Make sure I'm not misstating that. AC3. I'll get it right here in a minute. Cardiac arrest protocol. We are looking at the pearls. The pearls are at the bottom of each of your state protocols, and the pearls are very important. The state very intentionally puts this stuff here in a really easy to read format, bulleted, bolded, some of it even in red capital letters. That means the stuff that's found in the pearls is really important. So let's take a look. Team focused CPR pit crew approach recommended. What in the world does that mean? That means that as we're approaching this scene, and if we know it's already a code, then we're going to go ahead and have an approach, a plan in up our sleeve. So I guess what I'm trying to say. We're going to have a plan planned. How's that? I'm going to be in charge of airway. You're going to be in charge of working the monitor. This person over here is going to be in charge of doing chest compressions, so on and so forth. Everybody has a very well-defined role, and that prevents a lot of chaos. When you get on scene and something bad happens and everybody has to move quickly, then oftentimes you end up with either too many chiefs and not enough Indians, or you have a lot of Indians and nobody wants to take charge, and everybody's just in each other's way, and it just doesn't work really well. So if you have well-defined roles and responsibilities going into this scene, then you're going to do a much better job in taking care of the patient. What if you don't know it's a code when you get there? Well, then assign things when you get there, right? Oh crap, something happened. He just lost his pulse. Hey, get on the chest for me. Hey, will you grab BVM, start bagging this patient? So on and so forth. Also, somebody needs to take charge. Normally, whoever is taking charge is going to be whoever's turn it is to take the call. Normally, on a truck, we alternate. I take a call, my partner takes a call. I take a call, my partner takes a call. That doesn't mean that whoever's call it is, quote unquote, is the only person that can make decisions on this, and that they're a dictator and they make the only calls, and so on and so forth. It's still a group effort, and that's extraordinarily important, especially after the basis of cardiac arrest management is complete. Once you've done the basis of your protocols, and we're kind of focusing on where do we go from here, conversation is not only encouraged, it's absolutely a necessity at this point. So make sure that we're using team-focused CPR. Efforts should be directed to high-quality continuous chest compressions with limited interruptions and early defibrillation when indicated, and that is in bold, red print. So that goes back to what we talked about a few minutes ago in that early CPR, early defibrillation, those are the only two interventions that have actually been proven without a doubt beneficial for the cardiac arrest patient. Bold now and capital do not hyperventilate. So hyperventilating has been proven to be one of the most likely reasons that patients recode after you get ROSC. So when we hyperventilate, we expand the lungs. Obviously, this is positive pressure ventilation in comparison to negative pressure ventilation, which is what the patient's body is accustomed to. So when we force air into the lungs, it greatly increases the intrathoracic pressure. One of the big things that we're trying to do when we're treating cardiac arrest is increase blood flow to the heart muscle, because the more blood flow we can get to the heart muscle, first, the less heart cells are going to die, but second, the greater the chance of ROSC is going to be. A ROSC, R-O-S-C, that stands for return of spontaneous circulation. So there absolutely is evidence-based correlation between coronary perfusion pressure, meaning how much blood am I getting to the heart muscle, and the incidence of ROSC. So basically what that means is the more blood I get to the heart muscle itself, the greater the chance of this patient getting their pulse back is. Now ROSC is an intermediate or a necessary intermediate step, meaning that I have to have ROSC in order for the patient to have a neurologically intact survival. But just getting a pulse back does not mean that you save this person's life. It doesn't mean they're going to live. Okay, it's very, very common that the patient will rearrest after you get ROSC, and oftentimes when they rearrest, you will not get a pulse back. We'll talk more about that later. But do not hyperventilate, because hyperventilation increases intrathoracic pressure, it puts pressure on the inferior vena cava, and limits blood flow back to the heart. Therefore, hyperventilation alone decreases your chance of ROSC, which means it decreases the chance of this patient living. Passive oxygenation is optional, it says. So what this means, and it says it's optional, I highly recommend it. We talked about it with RSI. You're going to put a nasal cannula in the patient's nose at 15 liters per minute. Especially while we're doing chest compressions, even though we're pushing on the chest to compress the heart, you do compress the lungs to an extent, and you do suck some air into the lungs. So this is a passive way of continuously oxygenating the body. IVO excess drug delivery is secondary to high-quality chest compressions and early defibrillation. Again, it's preaching that compressions and defibrillation are the most important thing. Defibrillation, follow the manufacturer's recommendations concerning defibrillation. So typically what we say is we're either going to utilize 200 joules or administer 200 joules or the manufacturer's recommendations. The Philips HeartStart MRX, which is the monitor that we've had throughout the program until we got the new little ugly blue one, the manufacturer's recommendations was 150 joules. So even though the AHA says, hey, we can do 200 and we did 200 forever, Philips says we think that 150 on our, I think I said 150 twice. I'm sorry, I'm trying here. So 200 is what we did forever. Manufacturer's recommendation would be 150 for the Philips. It's also 150 for the Zoll. That's what the manufacturer recommends. So it's acceptable to do either or. End-tidal waveform capnography. We talked about this briefly a few weeks ago when we looked at ETCO2 for the first time, and we learned how a sudden spike in your ETCO2 values could indicate that you have ROSC. In fact, it likely indicates that you have ROSC, and you may actually see that spike in your ETCO2 waveform before you ever feel a pulse. Additionally, we can use it as a good qualifier for how well are we doing chest compressions. If the ETCO2 is less than 10, that means better CPR. Lock that in your mind. I promise you'll see that on the test. ETCO2 less than 10, you need to do better CPR. Your chest compressions are not adequate. Normally, we see that spike, according to protocol, typically greater than 40 millimeters of mercury, and that is going to be a likely indicator of ROSC. So special considerations, there's only one thing really that we do differently for a pregnant female, okay? If we think back to your OB stuff, we know that especially in late trimesters, late second into early third and throughout the third trimester, the patient is not supposed to lay on their back. Do you remember why that is? It's because of a condition called supine hypotensive syndrome. So basically what happens is the fetus puts pressure on the IVC and limits blood flow back to the heart. If you get less blood to the heart, then obviously you get less blood out of the heart. So similar to your positive pressure ventilation here, but it's caused by a baby laying on the fetus. So we may need to turn the mom a little bit over if she has a pulse. Remember, if she has a pulse, we're going to do the left lateral recumbent position. But since we're on cardiac arrest, we can't actually do that. So what somebody can do, though, is take the fetus and literally manipulate the fetus over to the left-hand side while the patient is lying supine, because we cannot do chest compressions with the patient laying on their side. This is called manual, how do they term it? They term it manual left uterine displacement. Literally, it means move the uterus to the left side of the patient's abdomen. That is our consideration with maternal arrest. Renal dialysis, renal failure, we'll talk a lot more about this later, but just know that the renal dialysis patient has an increased incidence of hyperkalemia, so we may want to go ahead and get on board with that and consider our calcium, our bicarb, maybe even albuterol bagged in, and we'll learn why those work later. Opioid overdoses, important to note, Narcan is not recommended in the onset of cardiac arrest, and the reason for that is the heroin that they took didn't kill them. The heroin that they took made them stop breathing, and hypoxia killed them. Very important distinction there. So when we're treating cardiac arrest, our goal is to treat the reversible cause. The reversible cause in this heroin overdose patient was not heroin, it was apnea. It was respiratory arrest, right? So you ventilate the patient, you're fixing what caused the cardiac arrest, theoretically, okay? So Narcan is not recommended in the use of opioid-associated cardiac arrests. Drowning, suffocation, asphyxiation, hanging, lightning strike, hypoxia is probably going to be a leading cause of death with all of those. Most patients, even with hanging, they don't jump off of something high enough to actually fracture the neck or fracture the hyoid bone. Oftentimes they literally just hang there and suffocate to death while they're struggling for their lives. Lightning strike, very high risk of cardiac arrhythmias. So this patient, obviously you can't take somebody against their will, but they have to go to the hospital. Okay, lightning strike patients have to go to the hospital. And we'll talk more about lightning strikes later. Our triage is actually reversed for lightning strike patients. You would work the patient who is in cardiac arrest before the patient who is nearing cardiac arrest if you had, say, a scene out in the middle of a field and you had 3 patients that were all struck by lightning. The person who's dead gets the most treatment. I know that's backwards from the typical triage, but we will talk more about that at another time. Transcutaneous pacing, we used to consider that in PEA and asystole. We no longer do, so it basically says it is not effective and not recommended. All right. So let's continue over onto our PEA protocol, PEA/asystole. Remember, they are treated exactly the same in this protocol. The most important thing in any cardiac arrest management, but especially in PEA, is to think about and identify the reversible causes, potential reversible causes of cardiac arrest. And I think that I gave you this last week on your quiz. We did actually, because we talked about this in bradycardia. So the H's and T's. The H's and T's have not changed. PEA is more than likely caused by hypoxia or hypovolemia. Those are the two most common reasons for someone to exhibit PEA. Again, if you don't know what PEA is, go back and watch the video on the cardiac rhythms associated with cardiac arrest, and it will walk you through that. So our history, our sample. Why in the world would your sample history be important for a patient who's in cardiac arrest? Well, the reason would be signs and symptoms. Obviously, they're in cardiac arrest. What about the history of present illness? What were they doing before this started? When was the last time that somebody saw them, talked to them? When was he last acting normal? When he went to bed last night, was he complaining of anything? Oh, you say he was having some chest pain and shortness of breath, but thought it was indigestion, so he went to bed. Well, now things make a little bit more sense, right? Always being treated for AIDS. Well, that could be a contributing factor as well. So your history of present illness, especially allergies, the medications that the patient is on. If you look through the patient's meds, you can get a really good idea of what kind of health problems they have. Of course, you don't always take meds for every single health problem that you have, but most of the time, if it's something that's significant enough to potentially cause you to go into cardiac arrest, you're going to be on some kind of medication for it if it is a pre-existing condition. That does not mean that people don't fall over dead every day for no apparent reason, because they absolutely do. All right, estimated downtime, very important. That goes into your criteria for death. Remember when we started talking, we said obvious signs incompatible with life, dependent lividity, rigor mortis, blunt force trauma with asystole and or PEA and or extended downtime. So when is the last time we know for sure that we saw this person alive? That's always a question that we need to ask. Oftentimes the calls that we go to that are cardiac arrest calls are first thing in the morning, and it's because somebody didn't wake up, right? And so now they've basically died in their sleep, died sometime during the night. And it makes a big difference if they saw them collapse into the bed 5 minutes before they called EMS, or if the last time they talked to them was 9 o'clock last night and now it's 9 o'clock in the morning. It could have been 20 minutes that they were down, but it also could have been 8 hours, 10 hours that they were down. So it makes a big difference, and this is where that body temperature does come into play. And in that period of time, 9 to 12 hours, you absolutely would have rigor mortis. You're probably going to already have dependent lividity. It depends on the person. All right. So reversible causes, we talked about that, your H's and T's. We will get more on that in just a minute. And of course, always make sure that we ask about a DNR, most, or living will. All right, signs and symptoms. So there's 3 signs and symptoms of cardiac arrest per the American Heart Association, and that is the patient's unresponsive, they're not breathing, so apnea, and they're pulseless. So unresponsive, not breathing, and pulseless. Your protocol adds in another thing on there, a couple of extra things. No electrical activity on ECG, which isn't necessarily the case, because with a pulseless electrical activity, VTAC and or VFib, that would absolutely be electrical activity, but doesn't produce pulse. And or no heart tones on auscultation. So that is a very important thing to do, is to auscultate for heart tones. It will be a little easier in the upcoming years because we as the EMS profession are migrating toward having ultrasound capability in the truck, and we'll actually be able to look under the xiphoid process here and see is there any cardiac activity. We're going to go ahead and pause on this video for just a minute before I get really into the PEA because I'm almost out of time.